So today I'm really pleased to be joined by Dr. Hannah Carver and Dr. Tessa Parks. So Hannah is a lecturer in substance use at the University of Stirling and also Deputy Director of the Salvation Army Centre for Addiction Services and Research. Her research interests include substance use, vulnerable populations, health inequalities, harm reduction and qualitative methodologies. Tessa Parks is Research Director for the Salvation Army Centre for Addiction Services and Research, Health or Social Care Services, with a clear commitment to social justice, health equity and advocacy for poorly served groups, including people who use alcohol and drugs. So you can see how both of their work really squares very well with the theme for this year's occasionals. I'd also like to congratulate Tessa on behalf of SARN and SHAAP on recently being promoted to Professor. Well done, Tessa. We're delighted for you and also delighted for alcohol research in Scotland. So today, Hannah and Tessa are going to present the research on managed alcohol programmes, often referred to as MAPs. This is a really exciting and innovative harm reduction approach for people experiencing alcohol use disorders and homelessness, originally developed in Canada. MAPs have had positive results, but very few exist in the UK and Ireland. And so Hannah and Tessa are going to present their findings from two CSO funded, that's Scottish Government funded, studies on the feasibility and acceptability of implementing managed alcohol programmes in Scotland. So I'm delighted to hand over, first of all, to Dr. Hannah Carver for a presentation. Thanks, Hannah.
So welcome, everybody. Today, Tessa and I are going to be talking about two studies, the findings of these studies on managed alcohol programmes, or MAPs, in Scotland. So just a bit of the structure of our talk. I'm going to be looking at providing with some background and context. And then I'll discuss the first study in terms of methods and findings. And then I'm going to hand over to Tessa to talk about our second study that was conducted during COVID, as well as some implications and next steps. So just a quick bit about us, although Carol's given you a little biography. We both are from the Salvation Army Centre for Addiction Services and Research at the University of Stirling. And this was a research centre that's been set up since 2017, funded by the Salvation Army to conduct research around addictions, and much of our research focuses on drug and alcohol use, homelessness, physical and mental health, and social inequalities. Tessa leads the centre and I'm Deputy Director. And while we're funded by Salvation Army, much of our external funding comes from other funders like the National Institute of Health, Chief Scientist Office and Society for Study of Addiction. So just a bit of background about who we are. So in terms of alcohol use, we know that global estimates suggest that alcohol use disorders affect around 237 million people, million adult men worldwide, and 46 million adult women. And harmful use of alcohol results in approximately 3 million deaths worldwide, which is about 5% of all deaths. And in Scotland, the rates of alcohol use and related harm are particularly high, with more than 1,000 deaths attributable to alcohol in recent years. So we also know that alcohol use disorders are not equitably spread across the population. And some studies suggest that there's a mean prevalence among men who are homeless of about 38%, and also figures for women are less certain. And in Scotland, homelessness affects a significant number of people. Approximately 51,000 people were affected by homelessness in 2019 and 2020. And people who are homeless tend to have higher rates of substance use and mental health problems than those who are not homeless. And these problems around alcohol use and homelessness are closely connected to complex social and structural processes and policies, and these create extreme social inequalities, poverty, and adverse life events. And alcohol use can be the reason for people becoming homeless, a response to trauma, poverty, and difficult life circumstances, and also a way of coping with homelessness. So it's a very complex issue. And we know people who are homeless tend to experience significant harms associated with their alcohol use, including acute harms like alcohol poisoning and seizures, as well as chronic health conditions like liver disease and cancers, premature death, poor mental health, assault and injury, and also almost inevitable social exclusion. And access to mental and physical healthcare services can be quite challenging for this group. So for many people who experience homelessness and alcohol use disorders, treatment options are generally quite limited. And abstinence-based programs are really difficult to comply with because there might be unrealistic or undesirable goals for people. Many people will struggle to access appropriate treatment services, and when they do, they often have no choice of approach, which results in repeated experiences of detoxification. So in this related review that we conducted looking at perceptions of substance use treatment for people who are homeless, and it was looking at international evidence, and we found that participants were generally more favourable towards harm reduction oriented approaches because abstinence-based treatment was perceived as challenging, particularly for people who are unwilling or unable to stop using alcohol and/or drugs. And harm reduction services are seen as compassionate, non-judgmental approaches, but can also, participants also recognise the challenges of being in environments where substances are allowed or available if they are wanting to stop using. And we also found key components of substance use treatments for this group, as you can see on the screen. These were things like facilitative service environments, compassionate and non-judgmental support, treatment that was long enough in duration for people to become stable, and also the importance of formal aftercare, having choices about the type of intervention that you receive, and also the opportunity for people to set their own goals with treatment, and also the opportunities to learn or relearn how to live. So learning skills around things like hobbies, computing, cooking, and meaningful activities. So we see treatment as being a very holistic approach. And we also recognise that these components need to be delivered within the context of person-centred care, relationships, and an understanding of people's complex lives. So for people who are homeless, there's a lack of evidence regarding more traditional treatments for alcohol use disorders. So there's things like pharmacological treatments and mutual aid, as well as evidence around occasional detoxification and provision of medical support, which can improve long-term health outcomes for street drinkers. But there's an expectation that long-term abstinence is unlikely to be achieved. So we know that the aim of harm reduction is to reduce harms and to meet people where they're at rather than imposing or expecting abstinence. So many treatments, as I've said, for alcohol use disorders do expect abstinence, and it can be particularly undesired or unachievable for people who are homeless. So we get harm reduction strategies for alcohol, including things like teaching people how to drink safely, limiting number of drinks, as well as other interventions that will reduce injury, violence, and public disorder. But compared to drug use, there are far fewer options and a weaker evidence base for alcohol harm reduction. So taking this all together, we know that for people who are homeless with alcohol use disorders, access to abstinence-based treatment is challenging and often unwanted or unrealistic. People might not have the desire or practical, unethical and impractical if people are expected to go back to living on the streets afterwards. Safe alcohol, this is alcohol programs, and MAPS provide structured and non-judgmental approach to alcohol harm reduction that does more than just educating people about safer drinking strategies. So MAPS are programs where alcohol is provided in measured regular doses throughout the day as an alcohol harm reduction intervention. As Carol said, they've been developed in countries like Canada as well as Ireland for people who experience homelessness and alcohol use disorders, who find it hard to engage with these higher threshold addiction services. And in Canada, there are currently 23 managed alcohol programs across the country, with at least 10 having started in response to COVID. The first MAP was set up in Toronto in Canada in 1997 in response to 3 men freezing to death on the streets. So MAPs are not new. They've been running for over 23 years. And they vary in terms of how they operate. So settings can include residential, like hostels or residential sheltered housing, drop-ins or day centres, or hospital based. In terms of people who are on MAPs, generally the services are quite small. Some are very small with a handful of participants, whereas one in Vancouver has more than 200 people, and many people are Aboriginals. Most are funded by government and health authorities. Some have a co-op model where people will pay for their alcohol. Some people pay rent or for their meals, and in some cases people will contribute to the costs of alcohol, and in others it's provided. In terms of the type of alcohol, it varies again. Some provide a choice of beer, wine or spirits, whereas others might just administer one particular type of alcohol. Administration calls 8 hours, and it can vary by individuals depending on their own drinking plan. In Canada in particular, some people who access MAPs do use non-beverage alcohol, so drinking things like spirit, hand sanitizer or methylated spirits, but it's not just the only focus. And it's particularly for people who've got chronic alcohol use disorders and unstable housing. And most of them provide not only alcohol and housing, but regular activities, healthcare, social and cultural programs, as well as assistance with life skills. And harm reduction is obviously a guiding principle behind these programs. And just to note that MAPs are generally operating in Canada, and the majority of research evidence comes from these programs. However, things are changing, and MAPs have started to gain prominence across the world. So in Australia, for example, Ezard and colleagues conducted a survey with people in Sydney who would be eligible for a MAP, and found that they were perceived to be acceptable to them, with residential MAPs likely to produce significant cost savings. And a recent report from Canada also recommended a MAP within the Northern Territory to address the challenges for those experiencing homelessness and alcohol use disorders. And then thinking about closer to home, in Ireland, the DePaul charity runs Sundial House in Dublin, which has been providing a MAP since 2008 for about 30 people who have histories of entrenched street drinking. Many people have up to 15 years of exclusion from housing and addiction services. And in 2010, DePaul produced a report of Sundial House, which showed that about 87% of residents had physical health needs, 40% had mental health needs, and 55% were classed as high alcohol dependents, with a small number also using drugs. Many people needed household, nutrition, and/or health and personal care support. Of the 44 people who'd been part of Sundial House since 2008, 5 had died, 1 had moved on to supported accommodation, 2 had gone into hospital, 4 had been excluded for violence, and 3 had left for other reasons. And 17 of these people sustained their accommodation. Most people were drinking 30 units or less per day, although there were 13 people drinking more than 40. And 2 of them reported being alcohol-free. And there were successful outcomes reported with some service users, including changing their drink of choice, for example, switching from drinking large quantities of spirits to something lighter like lager or cider, as well as slower drinking and reduced alcohol intake, which had improvements to people's health, as well as increasing their appetite and reducing behavioural issues. And Sundial has a pretty big centre with 23 staff, including managers, nurses, case managers, support workers, chefs, reception staff, catering assistants, and cleaners. So we're just going to watch a short video about Sundial House. It's about 7 minutes, just so you can get a flavour of what these types of services look like.
So my name is Ed Hannon. I'm the Deputy Manager of Sundial House. Sundial House is a housing project that was set up in 2008. The reason it was set up initially was to meet the need of people who'd be entrenched long-term street drinkers. There was a project before here called Angel Street that was an emergency shelter for entrenched street drinkers. And they found obviously as the age group and the age profile got higher, that more and more people needed a higher level of support. So Sundial House was set up with that in mind. So we'd have 24-hour cover here. There's a nurse on site 5 days a week. We have 127 hours of carer support for residents, because a lot of our residents would need support around their personal care and maintenance of their rooms, and that kind of one-on-one support would be needed by a few of our residents. The residents here, we manage a lot of aspects of their lifestyle, to minimise the damage that alcohol is causing to the systems. For example, every resident here would be on an alcohol management plan. So the idea behind alcohol management plan is that before these were in place, you have a situation with residents quite a lot where they would binge drink heavily on a, say, Wednesday or Thursday, and then would spend, they'd end up going through DT every week, and the physical effect that had on them was obviously huge. So we sit down with each resident and we work out a different alcohol management plan so we can spread it out over 7 days. It's obviously kind of budgeting as well. So bringing in the alcohol management plans have brought a lot of changes to the shelter and to the community, in the sense that residents are drinking consistently over a week. So they're more able to liaise with health services, and they're more able to liaise with the life skills and the holistic stuff that we have going on in Sundial all the time. The violent or kind of aggressive or behavioural issues are reduced because of the kind of consistent level, and obviously the physical damage that people are causing to themselves by going through withdrawal every week. By not going through withdrawal every week means that there's a lot of improvements in the kind of nutrition, as I said, personal care, a lot of aspects of our residents' lives. Every resident here would have a key worker, so each person has an individual key worker. They'd have then a support plan based around their needs to be drawn up with the key worker. So the support plan will cover a lot of different areas of the care. It will cover personal care, nutrition, budgeting involved in their care plans and in their care. All the residents here will be in touch with their families, and it is nice to see. I think it's good for the families that they can see that there are people that they care about are being looked after, people that they obviously, for whatever reason, they weren't able to manage the behaviours themselves. But I think for a lot of people, it's like a sigh of relief for them when the resident moves in here, because they know they're not going to be out drinking in the street. They know they're not going to be in and out of different shelters and different services, and they know we're going to work with them on site here, that we don't exclude people. We work with behaviours. So people are mostly in-house. Our residents, the large part, would drink on site. They wouldn't drink in the area surrounding the shelter. So it's good for the local community too, that people aren't drinking on the streets, and the antisocial behaviour that comes with that, and obviously the vulnerability that poses for a lot of our residents if they would be, more vulnerable out on the street to getting attacked. So the families, you can see with families when residents move in here, they're delighted that people are actually being looked after. Our residents can stay here indefinitely. This is a bed for life, because that's the long-term housing aspect of it. We have a huge team of volunteers here, which is excellent, that engage with residents. Obviously staff quite busy here with managing the alcohol, managing budgeting, managing medication, personal care and health and safety stuff that obviously they unfortunately probably haven't got as enough time as they would like to sit down one-to-one with residents. So that's where volunteers come in very handy. One of the main things that would happen here every day, Monday to Friday, would be a breakfast club. The idea with that was to get the residents to meet together earlier in the day. So what I see as being one of the very positive points of Sundial House is our residents, obviously, with the low threshold approach to them, our residents that we work with, these would be people a lot of times will have behavioural problems, and would have in the past been excluded from a lot of services, wouldn't be allowed to engage with services because of their alcohol use, and would have slept out on the street, would have been engaging only in emergency services very late at night. In Dublin we used to have a system called a night bus, which used to go and collect people very late at night and bring them to shelters. But it's very important, obviously, for the local area and the local community that we're here, because it has reduced the level of street drinking and antisocial behaviour in the area. We would meet with community groups. We have a community guard that would be a police officer that's linked to the shelter. So we would talk to him, we'd ring him if we have any issues, if we think anything is going to become an issue. If we have started noticing any antisocial behaviour, he can come in sometimes. All he needs to do is say one thing and it kind of can calm down entirely. I would be like obviously linked in quite closely with the Dublin City Council and local TDs.
That gave you a bit of an overview of the types of services included within a MAP. So taking it over to Canada and looking at some of the research, several studies on MAPs in Canada have had really promising results. For example, Polly and et al. In 2016 conducted a mixed method study with MAP participants and controls. And MAP participants were much more likely to retain their housing and experienced increased safety and improved quality of life compared to living on the streets, in jails, or in shelters and hospitals compared to controls. They described MAPs as a place of safety, characterised by caring, respect, trust, and a non-judgmental approach with a sense of family and home, as well as opportunities to reconnect with family members. Stockwell et al. In 2017 conducted a survey with MAP participants in 6 MAPs, as well as controls who would be eligible for a MAP, and they found that both groups of participants had similar SADQ or alcohol use disorder scores, and participants who were newer to the MAP tended to drink more frequently than controls, but didn't differ in terms of the number of drinks per day. And longer term MAP participants drank significantly fewer drinks per day, but they drank for more days in the past month than controls and the newer MAP participants. So while the overall volume of alcohol was similar, the pattern of drinking was much more evenly distributed across days for long-term MAP participants, as well as non-beverage alcohol use being higher among those who had newly joined a MAP compared to those who had been there for a while or controls. And also long-term MAP residents were less likely to report any one of 11 alcohol-related harms, including things like violence, housing, and withdrawal seizures. So while MAP participants who'd been there for more than 2 months drank more frequently, they actually drank less alcohol and experienced less harm. So it suggests a smoothing out of drinking for the longer term MAP participants in particular, compared to people who were drinking in more intermittent, chaotic ways at the beginning. And the change in drinking was also accompanied by significantly fewer acute alcohol-related harms, like seizures or being assaulted, as well as social harms like relationships, legal, financial, and housing problems, as well as improvements in self-related physical health and cognitive functioning. And Hammond et al. In 2016 conducted a cost-benefit analysis of one MAP in Ontario, and they found that the cost per person of health, shelter, and police service utilisation was much lower compared to people's use before they joined the MAP, as well as controls, with around 13,000 Canadian dollars spent each year compared to about 45,000 for those who were prior to the MAP. And then finally, the most recent study by Stockwell et al. In 2021 showed that there were reduced harms for people who were on the MAP, as well as when those people left the MAP, their liver status tended to deteriorate. So overall, these are just a handful of studies, and there's many more, but it shows that MAPs can reduce alcohol-related harms, improve relationships and quality of life, well-being and safety, as well as reducing alcohol intake and helping people to retain their housing and helping them to feel safer and have opportunities for healing and connection. So alcohol harm reduction is complex and can be viewed as ethically challenging because alcohol is obviously a poison that can pose significant risks to people's health and safety that are dose dependent. And as alcohol consumption continues, when someone joins a MAP, there's a need to recognise that while the evidence for MAPs is positive, there's still the need to assess these long-term heavy drinking, although Stockwell and colleagues did look at this in their latest paper. So that takes us on to our first study, which was funded by the Chief Scientist's Office and in 2019. And it was a mixed method study looking at the feasibility of MAPs in Scotland. So it aimed to scope the feasibility and acceptability of providing MAPs within third sector homelessness accommodation, to look at how we might tailor MAPs to a Scottish and UK context. So the objectives were to scope the target population in terms of the people who would benefit from a MAP, looking at the attitudes of staff working in services, commissioners and strategic decision makers, as well as those people who would be eligible for such a service. So the study was led by Tessa, along with myself, Katrina Matheson, Bernie Polly and Tanya Brown. And we received ethical approval from the University of Stirling, Salvation Army and Turning Point Scotland. So in terms of the methods, it was a mixed method study. First, conducted concurrently. So we conducted a case note review within 7 Salvation Army services and 2 Turning Point services across Scotland. And we extracted data from 33 people's case notes to look at their health and social issues, and a range of data, including things like alcohol use, housing status, demographic characteristics, physical and mental health, addiction treatment services, and other things. These were entered into a spreadsheet and then subsequently analysed in SPSS. We also conducted interviews with 29 people, so 12 strategic level informants, so generally people in government, NHS or leadership roles within third sector organisations. Frontline homelessness services staff, 8 people, and with 9 people who would meet the criteria for a MAP. And we looked at alcohol use and the needs of the target population and people's perceptions of MAP. And we used 3 vignettes to explore the different approaches with options around residential, drop-in and co-op models. And these interviews were transcribed and analysed using framework method. And additionally, we did a bit of a mapping exercise to look at identifying services across the UK that operated as MAPs based on the information that we found by looking at searching on the internet. And we've identified 5 services across the UK that appear to be operating, at least to some extent, as MAPs. There are 2 in England, 1 in Scotland, which is Rowan Alba's Thorntree Street, 1 in Wales and 1 in Northern Ireland. And they were all residential, and 4 of them were available to both men and women. And all of these services could be considered as drawing on MAP approaches because alcohol is stored centrally and provided at regular intervals, and a range of support services were provided. Other services exist that allow alcohol on site in clients' rooms or in designated areas, but they wouldn't meet the criteria for MAPs because they're not alcohol is not being centrally held. And there's also likely to be many more services that operate as MAPs but are under the radar. And it's important to note that while Thorntree Street appears to have similarities with MAPs, they don't really view themselves as such. And it's not managed for all clients, only those who need it. And it's also important to note that no evaluations or studies have been conducted in these MAPs. So this is the first study in Scotland. So in terms of the case note review, we found that generally participants were male and aged 30 to 49 years. Physical health problems were reported for 54% of people, and almost most of them included things like respiratory problems, joint and nerve pain, infectious diseases, and so on. 97% of the case notes had the presence of mental health problems, and this tended to be depression or anxiety or post-traumatic stress. And alcohol use, as you can imagine, was incredibly high, with everyday alcohol use reported for 26 of the 33 people. Units ranged from 10 to more than 100, and wine and spirits were the most commonly consumed types of alcohol. 75% of people experienced daily withdrawal seizures or daily withdrawal symptoms, and about 15 people had weekly seizures. About a third had been in previous alcohol treatment, and about 2/3 had had previous alcohol detoxes. Hospital admissions for alcohol use were experienced by more than half, but there was only one alcohol-related ambulance call-out. And also cognitive impairments were also reported for 10 people. And also 58% of people used drugs as well as alcohol, particularly heroin, benzodiazepines, cocaine or crack cocaine, and cannabis. And we looked at associations between drug use and alcohol use units. And there were no associations between the daily number of units and use of heroin, methadone, cannabis, cocaine, or benzodiazepines. So from the case note review, our study shows similarities to people accessing MAPS in Canada, who are typically male with high levels of drinking and high rates of daily drinking, which suggests the need for MAPS in Scotland. So I'm going to quickly go over the key themes from the study, looking at 4 in particular. So the need for MAPS. Participants talked about the need for MAPS in Scotland for those who are experiencing homelessness and alcohol use disorders, and were clear that these services are typically lacking across the country. They were generally positive about the prospect of introducing MAPS because there's a strong sense that alcohol harm reduction was underdeveloped. And they talked positively about the way in which MAPS could fit into current service provision. So as you can see from the quote on the screen, one of the participants who used a homelessness service was clear that they would personally benefit from the MAP. They said that they would stop drinking, that it would be beneficial because they might, by stopping drinking, they would go into fits, they would be shaking. So it wasn't beneficial for them to try to stop. In terms of eligibility, participants also discussed the importance of being clear about who MAPs are intended for and the individuals who would benefit from them. And there's consensus across all groups of participants that MAPs would be best suited to those who've been excluded from other services who are considered disengaged. And the overall view of participants was that individuals would best be suited to provision of a MAP. It would be those who had tried other services and interventions, who had not benefited from them, or had struggled to keep their tenancies because their dependency was too severe. As you can see from this strategic participant, who says it's presumably the most disengaged who have tried, they probably ping-ponged back and forward between all sorts of services, and they have a real dependency on alcohol. Participants also reflected on the potential challenges of providing MAPs in Scotland, where there's high rates of polysubstance use, so people using both alcohol and drugs. And that's reflected in the case note findings. And many staff gave anecdotal evidence of clients and residents using benzodiazepines, cocaine, cannabis, and heroin or methadone alongside their alcohol use, and the potential challenges of providing support to individuals who are using alcohol and drugs within a MAP. And some potential beneficiaries also talked about their own and others' polysubstance use. And as you can see from the quote from the staff participants, they said that while most people are alcohol dependent, there's been a massive rise in polydrug use. The classic drinker are also using things like street Valium. So overall, participants were clear that alcohol harm reduction services are needed in Scotland for people who are at high risk of harms due to their alcohol use and their housing. People were clear that MAPs would be valuable for those who had exhausted all other treatment options and were in need of alternatives. And the high rates of both alcohol and drugs in the group was viewed as a particular concern in Scotland that needs to be considered when developing services. So we also identified 6 key components of MAPs that need to be considered in Scotland, and I'm now going to talk about 2 of them. So as I noted before, MAPs are more than just providing alcohol, and participants talked about the importance of MAPs in being holistic. There's a recognition of the need to take a holistic approach which considers a range of aspects of people's lives, like their mental and physical health, housing status, finances, skills development, and meaningful social activities. Healthcare was mentioned by many, with some participants having the view that a nurse or GP should be on site to deal with the many physical health problems. But others saw that actually it'd be important for people to engage with mainstream health services, which could encourage the independence. And all participants viewed the provision of social activities within MAPS as important, as a way of reducing boredom and social isolation, as well as building self-esteem and developing relationships. And you can see from the 3 quotes from strategic staff and potential beneficiaries that doing something would be really important within a MAP. And then finally, in thinking about autonomy and rules, when we presented 3 different types of MAPs to participants, they discussed the need for a balance between service rules and individual people's autonomy. So in one of the vignettes, alcohol was provided every 90 minutes, as it is in some of the MAPs in Canada. And people have to stay on site an hour beforehand to get their alcohol. So some participants were concerned about the rigidity of this approach and felt that flexibility in rules and structure was required. And a strategic participant noted that people might find these rigid rules really hard to stick by. And participants also talked about the need for people's autonomy in terms of like money provision, particularly around purchasing alcohol. And participants who were potential beneficiaries discussed the benefits of MAPs in supporting people's budgeting and working with them to identify how much money could be spent on alcohol. And they described experiences themselves of services where money is managed by staff to support their budgeting. And as participants said, if it's got a good structure, that could be a good thing. Some people like structure. It might be difficult to start off with in terms of structure, but it can be a good thing, and people would get into the swing of things and start to be involved more. So participants highlighted the need for support for people accessing MAPs in terms of encouraging autonomy, providing opportunities for people to make their own decisions, to build self-efficacy and self-esteem, and the importance of ensuring that people were in control of their support. So I'm now going to hand over to Tessa to talk about our second study.
Thank you, Hannah. Yep, we were fortunate enough to have another set of funding from Chief Scientist's Office for Scotland, which was part of the Rapid Response Programme in response to COVID-19 to inform health service delivery as part of Scotland's response to the pandemic. So there was 2 main research questions here, which I'll let you read. But really that was about applying what we'd learned in the initial MAP study to the pandemic and the implications of MAPs for further delivery in Scotland. Thanks, Hannah. Okay, so this is our study team. So pretty much the same team with some more folks added, because this was a study that had to be done in 6 months. So we really had to get our skates on to get the work done within that period, which was really challenging, but we managed it, and we had a brilliant team of researchers and supporters through our study steering group as well. No conflicts to declare again for this study. Thanks, Hannah. So the methods, we use similar methods to the ones we developed for the first study. So another case note review. This time we managed to secure case note records for 12 people. Again, looking at some of the similar things that we'd looked at before and entered into the spreadsheet in a similar way. Again, we did interviews, semi-structured in-depth interviews with a range of different groups, from external stakeholders, and the numbers are there, service managers who are delivering services within Salvation Army. And I should say that the study this time was just a study within the Salvation Army services in Scotland. We wanted to speak to frontline staff who, of course, very challenged at that particular period of time. So that was last May and into September during the pandemic, the early weeks and months of the pandemic, and also people who would potentially be beneficiaries of a MAP if it was implemented. So we were exploring, as I said, some of the similar issues around MAPs, but definitely in the context of delivery within a pandemic. Okay, thank you very much, Hannah. Just to say, we also commissioned a series of paintings from a wonderful artist called Linda McGowan, who's based in Glasgow, and we worked with her on another project where people might remember some of her art for us, Scottish University's Insight Institute programme that we ran collaboratively with other institutions. So Linda's part of the Unexpected Gallery, which is a social enterprise based in St Enoch Centre in Glasgow, and Linda and her gallery manager, Stu Duffy, were the artists, kind of artists in residence for this project. The reason we had the art as part of it was recognizing that it's very challenging in the pandemic circumstances to, of course, collect data. One member of our team did manage to collect some face-to-face data with clients, but just about everything was online, including our meetings and discussions about the study. So this was an attempt to create visual images as part of the project to in a way, track some of the process of doing the research itself, as well as the themes. This was a really successful element of the project, and we're going to show some of Linda's paintings through the rest of the talk. Because of the volume of qualitative data as well, I should say that for this particular presentation, we're just going to be focused on the COVID-related findings. There's another wealth of findings that we're going to be presenting possibly in the future, and preparing for another paper, which is more about the implementation challenges and building on the work in the other studies. So we're only presenting on one main theme and sub-themes. Thanks, Hannah. Okay, so these are our findings from the case note review, and we're kind of going through really quickly, but very, very similar findings, unsurprisingly, although of course this was just within one organisation in Scotland, but three or four services we were collecting case notes from. Clients. So again, most people we were collecting case notes from were men, and you can see here huge numbers of people, although there was only 12 overall. The majority experienced physical healthcare problems, 100% mental health problems, 50% used alcohol every day, with most drinking at least 20 units per day. 92% have been drinking for more than 20 years, and audit scores were really high, ranging from 14 to 36, with a mean score of 30. So certainly many people, the majority would have been diagnosed with alcohol dependency and alcohol use disorders. 100% of that small sample reported daily withdrawal symptoms. So when we're thinking about risks of seizures and other harms, very much high risk individuals, 58% reporting seizures. Most of the previous experience of alcohol use disorder treatment, detox, and hospital-related admissions. But frequently, as Hannah was saying, this ping pong effect of going in and out and then back into street living as well. 67% of people had alcohol-related cognitive impairments, and perhaps very surprisingly for this audience, perhaps 100% of that sample of 12 also were using drugs, illicit drugs, street drugs, with 58% of that sample using multiple drugs. We also gathered information about COVID. That was something very different from the case note review that we did before, and only one out of 12 people had experienced COVID-19 symptoms and been tested, and one person had been shielding. And for those outside Scotland, this was people that were recommended by our health service to protect themselves with physical distancing and stay at home. Everyone was told to stay at home, but they were put in a different category because of their health condition, and were told to shield. And nine of the 12 people actually broke lockdown rules in terms of what was recorded in the notes anyway, to consume alcohol. So I've rattled through that. There are a few other high-level findings there. For example, we were interested in non-beverage alcohol use, because that's one of the risks, certainly in Canada and other places, when people can't get access to illicit alcohol. But we didn't have anyone reporting NBA use, as it's called. So again, it's really just to paint a picture of people's complex needs. And we know people have multiple and complex needs, but this was one way of us sort of tracking that through the notes that were being taken. And of course, lots of things, particularly in the pandemic, weren't recorded, because certainly Salvation Army staff were prioritizing relationships, building trust, and ensuring engagement with the people that were using their services. So it's just to say that this is probably underreporting many of those, certainly the COVID-related activities. Thanks, Hannah. We can go forward onto the interview findings. So again, a bit of a whistle-stop tour through our interviews. We're writing it up at the moment for publication. certainly submission to a journal that's a special issue looking at health and homelessness. So as I said, one major theme of our qualitative data related to COVID, unsurprisingly, given that was our one of our main focuses and aims for the study. And then there were 5 sub-themes related to this, and I'll take you through those one by one. Thanks, Hannah. So the first theme or sub-theme from the interviews was COVID-19 related changes to services. So here's some quotes, one from stakeholder and one from client potential beneficiary for you to have a read of. So inevitably, the pandemic changed the way in which substance use and homelessness services could support clients, obviously since indoor one-to-one support was no longer feasible due to the restrictions. So there was a necessity of service adaptation to fairly instantaneously, although very challengingly, and many services responded in creative, innovative ways. And this was a case across the board, of course, not just within Salvation Army services, which we were focused on. So many services were moved online, which many of us already know. And some of this worked really effectively to broaden the number of people who were able to get support, and many solutions and approaches were kind of sped up because of the pandemic. Some of the clients experienced the change to be limiting support, but others talked about the benefits. And this quote here was about somebody who actually felt that the pandemic had brought benefits in terms of engagement. So they're saying it's actually quite good compared to the past. I never used to really engage with some of the services. So I think the stepping up of harm reduction services more generally, although those were mostly around homelessness in general and around illicit drugs, some of those benefits were felt by some of the people we were speaking to. Some people that we spoke to talked about a massive shift in organizational cultures. Some people talked about it as a curveball in terms of thinking about moving from absence-related provision for people who had alcohol problems to harm reduction, just because that's really not necessarily been the culture of services in Scotland thus far. So yeah, it was very challenging, and many of our stakeholders and service providers talked about some of those challenges, but also some of the benefits. So one of the managers, for example, said, "This is to save a life." That would be in terms of providing alcohol. It's the same as providing someone with naloxone. So talking about the kind of scale up of naloxone response for people who use drugs and a risk of overdose. So in summary, in terms of this sub-theme, participants reported that services responded quickly, flexibly, and really collaboratively and creatively in response to challenges introduced by COVID-19 pandemic. There were relaxed rules regarding absence in accommodation, for example, and these expedited entry into substance use treatment sometimes as well. The 2 curated paintings we've put for you to have a look at were created by Linda to depict the COVID-related changes to these services, in particular the increase in outreach services. So thanks, Hannah. We'll just show the audience the first and the second. So this is one that Linda did very early on. And there was a series of 10 creative paintings, and this is the first one that she's done, and the second one really about that street outreach. It's not the whole painting, obviously. And just to say, for those who want to know more about the paintings, we're going to hopefully, once restrictions ease in Glasgow, have these paintings put on in a gallery for public access, along with some of the findings of the study. Thanks, Hannah. So our next theme was, sub-theme is changes to alcohol supply and use. So you can have a look at some of the quotes here, but we were trying to get a picture of whether alcohol use went up, went down, stayed the same, and many people we spoke to talked about it being a mixed picture. Some people described the escalation in individuals having problems with alcohol use, and that the relationship with substances had been exacerbated over the time, whereas others have pulled out the issues around begging and not having access to funding, which for alcohol, which I know has been picked up in other studies. I know that that's something that we've been keeping an eye on too. Some others have said that the opportunity of the pandemic helped people to stem their drinking, really thinking about the decisions that they had in front of them. So yeah, I mean, even though our sample was fairly small, we did have a lot of diversity that we managed to capture in the interviews that we had. In summary, participants felt that for some people, actually alcohol reductions. Sorry, I just wanted to make a point about alcohol as well as drugs. So significant risks around alcohol with related to withdrawal because people were not getting access to alcohol in the same way. And a key finding, I think, for us was around illicit drug use as well. And many of our participants talked about people substituting alcohol with illicit drugs, including benzodiazepines, and that they were additionally at risk for that reason for a range of drug-related harms as well, including overdose. So this was clearly also linked to isolation. I just wanted to ask Hannah to go on to the next slide as well. I think we've got another painting here depicted by Linda, but just really wanted to underscore the issue that clients and staff participants raised around social isolation, which is really a theme of many of the studies that have been done around people who use drugs, but it was very much a feature of this study as well, unsurprisingly. Thanks, Hannah. So on the next sub-theme is people with alcohol problems being viewed as second-class citizens. This was a shocking but quite unsurprising finding for us in some ways, given the work we've been doing in this field and others as well. So the stakeholder participants talking here, what we found was that at the start of COVID, alcohol services were an early casualty of COVID. We had many reports of alcohol services diminishing very quickly. And there were examples of alcohol facilities being used for other purposes and drugs being prioritized ahead of alcohol. So again, some of the similar themes to the study that Hannah presented on. But yes, this was a feature that some of the nonprofit sector were trying to take up the contents that were lost in terms of statutory NHS services. One of the clients, for example, said, I'm going to have to wait months and months and months and months down the line before anything gets done. So it's just a roller coaster. And another stakeholder said the advice that we were given by and large was to continue on alcohol. It's not safe to currently detox you. We can't put the time and support in around you. You're going to be socially isolated. This isn't a good time to do detox. So the painting next, thanks very much, Hannah, was created by Linda to show the range of emotions and feelings experienced by people, and particularly clients of the homelessness services during the pandemic. Overall, there was a view that the availability, therefore, of alcohol services had diminished during the pandemic, resulting in reduced support and increased isolation due to stay-at-home rules. This had reinforced the view of some alcohol services that alcohol services were perceived as less important. Now, our role isn't to emphasize drugs or alcohol. It's really just to give you that perspective from participants that they felt that alcohol service users were not receiving the services that they needed to. Thanks, Hannah. I'm going to move on to two further sub-themes. You've been listening really well, and so we've got some more to continue to say. We'll come back to some of the points in the chat here. So potential for MAPs in the context of COVID. So this is, I guess, the bread and butter of the study, really. So a couple of more quotes here. Really, overall, huge support for MAPs. We were speaking to a very different group. We were keen to talk to different people than we talked to in the first study. It was really the case that many, in a way, people felt that the COVID response required MAPs, and it was really an important service development. However, I need to say that they weren't developed. They were not developed in Scotland. And I think for the paper that we're just trying to pull together at the moment, it's really important to highlight that even though the case is so strong, we haven't managed to create a map in Scotland related to COVID, although of course I know that Lorraine's on the call, Lorraine McGrath from Simon today. There have been plans for considerable amount of time for a map to be provided in Glasgow, which we're hugely supportive of. But there's a need for it in many cities, in my opinion. So here's a few quotes just to support the case again from clients and stakeholders. So again, across transmission, risk of infection, the benefits of a map there. Let's just go to a couple of other things. So yeah, I think it's important to say that with the quantitative data we've reported to you as well, it's clear that MAPS would prevent people, if you're supplying alcohol to people within their accommodation, then you're going to stop the need for people to have to leave the premises to secure alcohol, or, for example, if they're substituting drugs as well, to leave the premises. And I know from anecdotal evidence as well that the police were sometimes picking people up and didn't really have anywhere for people to go, because they were quite often the only people that were out and about on the streets for reasons of substance use. So, I mean, it's kind of some obvious links there, just to reiterate. But what we've also said in the presentation is the importance of MAPS providing other support and engagement with other elements of services. And I think that's really important. It's not just about the alcohol. One stakeholder, for example, talked about how MAPS could reduce the isolation concerns that we've just been speaking about and provide meaningful relationships, interactions, activities going on, compensating for what we're taking away, being really aware of all the things that were being removed from that client group at the same time. So the paintings that are coming next illustrate the finding that MAPS are not just solely about alcohol, but also about reducing isolation and barriers to healthcare and treating people with respect and dignity. Thanks, Hannah. Here we go. See there, that's one of my most favorite paintings that Linda did, of that sense of community and interaction. And the next one, thanks, Hannah. So with growing awareness of the need for better harm reduction relative to alcohol, participants spoke about how the pandemic presented an opportunity for MAPS to be implemented as part of national and local citywide responses. They talked about the fear of COVID-19 and how that had brought a sense of urgency to the table that wasn't there before. They said, I think it will save lives. We're going to give it a go. Unfortunately, they're not happened yet, but of course, we're not out of COVID and there's plenty more opportunities to continue. Okay, thanks, Hannah. So I think this is my final sub-theme. So this is the concern. So of course, there are a lot of fears and concerns that Hannah's already talked a bit to, and the service manager is really speaking to that moment in time early in the pandemic and get back into that period around, let's say, May, June last year. People in this moment of time, we're talking about a map within this framework. People are feeling really safe, unsafe. People are feeling really unsafe at the moment in general. One of the biggest barriers is going to be that feeling of safety. That's for staff and also safety for clients and beneficiaries. But basically, people's sense of vigilance is going to be really heightened. And the idea that you're giving the thing that you know is causing harm to the person, to not cause them harm. It can seem nonsensical. Why would you do that? If that's causing the damage, why are you going to give it to them? But this was a proponent of MAPS, and it's just thinking about the conversation that needs to happen with staff, the guidelines that need to be put in place to address either these cultural differences and also some of the hoops around licensing and inspection regimes and things too, which I know that Simon and community have been engaged with for considerable amount of time. So what we're not saying is that it's easy. We're not saying it's straightforward to bring people alongside you. And some people also spoke about the need to take communities and neighbourhoods, residential communities alongside as well, in terms of doing a bit of a PR job for MAPS, for this wider acceptability. So moving on to our implications. So thanks, we've just covered 2 of those studies, and this is our final couple of slides really on the implications for policy and practice, which are huge. And many of these you'll know already, and I hope you can read this small writing, but there's a number of implications from both studies, and we'll put them together on one slide for you. So we believe MAPS are required in Scotland as a harm reduction approach to managing alcohol-related harm. And there's been some comments in the chat around, well, are they just for people who are homeless? Generally, yes. But people can quite often be at risk of homeless and be, bounced in and out of short-term homelessness accommodation, and then maybe longer term, but they still may be at risk of homelessness. It is really an approach for people who are homeless, but it's also, I think, important for people who are more broadly vulnerable to homelessness. The MAPS need to be taking into account the high risks of polysubstance use and mental health problems, physical health problems, as you've seen there from the case note reviews that we've done. It's not just about alcohol, it's really about joining up a whole range of services that people, if they're not in stable accommodation, they just can't access. we believe that maps should be tailored to local and individual needs, so they would be different. I mean, Sinead's just put a comment in the chat around the Aberdeen service and Glasgow service, that we need to be tailored to the cities as well as individual organisations and individual needs. I certainly think that we could be looking at residential and also drop-in settings, but of course that brings a range of challenges, particularly in COVID, in the pandemic. Some of our findings coalesce with other studies we've done around the need for staff to be well-trained, compassionate, and non-judgmental, including having a good, strong engagement from peers and people with lived experience. I think I've already said they should be more than about just alcohol, and they should be helping people access a range of health and social care supports as well, including, as we just heard from the Irish map, the Dublin-based map around family re-engagement, which I think is a really, really important component of MAPS, and it's been written about in the Canadian studies. MAPS should present an opportunity for, they absolutely present an opportunity for Scotland in terms of the COVID pandemic, but they need to be continued to be tested and evaluated. So I think, and our team thinks, that we need to be looking at feasibility and pilot studies next, focusing on client outcomes. Thank you, Hannah. So we just put a few pieces of knowledge dissemination, knowledge and action work that we've been doing, including publications and also a piece for the conversation. And Hannah's done a COVID-related bite-sized lecture as well, if you're interested in learning more. And our last couple of slides around acknowledgements. Very, very thankful to Chief Scientist's Office for funding both studies. We're hoping to do a bigger, more ambitious study just in terms of actually supporting services to evaluate MAPS in practice. And a big thank you to Carol and others who are on our research advisory groups, the strategy group. I don't know if anyone's here from that, from Salvation Army, that really we worked as partners in doing that second COVID-related study. A huge thank you to Linda and Stu for bringing the work to life and helping us to disseminate, hopefully when we're allowed to do that in person, and of course to our participants at all levels. For more information, we've put some hyperlinks there for you, but we're very happy for you to be in touch if there's anything else you wanted to know about the study, and we've got time now to take some questions. Thanks very much.
Thank you so much for both of those fascinating presentations. There's loads of chat and questions already, as I'm sure people aren't surprised given the interest in this topic. So I'm just going to take some of the questions in the chat, some of the more kind of shorter, more factual questions before we go on to a more detailed discussion. So I think some of the questions that have come about are about definitions of MAPs, and what is a definition of a MAP? Why do some services regard themselves as a MAP and some don't? So perhaps Tessa and Hannah, you could talk to that question.
Trying to read Hannah's expression. Did you want to take that one, Hannah? Or?
So why are some, is that related to this, the kind of maps across the UK rather than maps in general?
Yeah, I think people were just asking what is the definition of a map, and then throughout your discussion you referred to some maps not regarding themselves as such and some being under the radar. So I don't know if that's about the cultural context in which they're operating.
So it would be, I think, the fact that it provides alcohol in measured regular doses, where it's held centrally and then kind of given out to people hourly, every few hours, daily. So it's not kind of like a wet centre where people just come and drink. It's more than that. Can provide residential accommodation, but doesn't necessarily have to, and provides kind of a range of holistic services for people who would meet the criteria of alcohol use disorder and homelessness or at risk of homelessness. So there's some services in the UK where, for example, it's a homeless hostel and they allow clients to drink, but they can just drink in their rooms. So that's not managed in any way. It's a kind of, there might be a kind of map approach for one person or a couple of people, but it's not the service model. So I think that's kind of what makes it different. And I guess in terms of under the radar, we were trying to find services by searching on the internet, and some of them just don't promote themselves because we know that people find them really controversial, and the person who set up the first map in Canada received death threats. So you can see why people maybe kind of don't promote the fact that they're giving alcohol to people with alcohol problems. So that's kind of just been how we've come across some, but there'll definitely be others who just don't promote it. And the one in Dublin, when we visited it, we actually couldn't find it because they don't kind of have this big sign saying alcohol here. It was just kind of like a nice building. So I would say that's kind of what the issue is.
Thank you, Hannah. Eleanor Jane asks, is a map such as Sundial House part of a journey? So once people are stable and have met their goals, is there somewhere else to move on to, or is it an ongoing service and a place to live?
I think the person from the poll in the video, I think his name was Ed, was saying it's really a home for life. The idea is it's a home for life, similar to what Helen would probably say about Thorntree. It's not medicalized, and the idea is it's not about moving people on. And that's partly because of the age that some of the folks are at, and because of the co-occurring physical health care problems, to be honest. So they had a nurse. You didn't see the whole video, but I would recommend you do that because it's just 20-minute video. It's really interesting. But there is no pressure for people to move on, and that would be the same in most of the Canadian maps. However, if people do want to move on, and people can move on, that's a really important part of the journey for some people. But there's no pressure to do so, and it's about that sort of having a dignified home life. So yeah, I don't think it's about this kind of short-term viewpoint, really. And hopefully that will, but every individual is different. So hopefully that takes care of that question. And all of the maps are different as well. So that's it. There's like, is it 30 odd maps now in Canada, Hannah? So they're all, quite a lot of the comments relate to the fact that they run quite differently. Jonathan's comment is about some of the maps actually have much more clear guidance about, for example, not drinking outside of the map, that kind of thing. And some are have less guidance. So we're kind of generalizing, we're talking about maps because it's really a very diverse picture.
Absolutely. And we've got a couple of questions about stigma. So Felicity Garvey asks, she's commenting on the idea that family is so important in MAP projects. Is there any evidence to suggest that stigma of relatives being in such a programme would prevent families from making contact? And related to that, Eric Carling asks if there's any findings or recommendations about engaging the wider community, including to reduce stigma and discrimination.
Well, the first one I'll take quickly first from Felicity, thank you. What Ed says in that video is that actually relatives are really, I think he said that in the clip that we had, really, really happy to know that their person that they love is safe. And there's a lot of engagement between the service and family members. And I would say that actually encapsulates most that's written about with regards to maps, particularly in Canada, actually, because there's a lot of, there are maps for the Indigenous communities and First Nations communities. And it's almost like in some of the maps up in the Northern Territories, there'll be an emphasis on a culture where the elders have activities, and families are a really important part of that, and reconnecting with families are a really important part of that. So I would say it's actually the opposite, Felicity, that the family members feel that they can embrace. Of course, there's lots of very hard emotions to re-engaging back with family. And Jackie, who was in that video, that we cut Jackie off because of the time we had, but she speaks about getting connected back to her children. And that's been a healing and facilitated process that Paul's been able to do with her. And she's really emotional when she speaks in the video. So I think that's really the take-home message from what I read, is that actually it can help with some of that, the feelings and also the stigma that's been associated. It doesn't mean you can suddenly get rid of stigma and community stigma by having a map, but I think it's part of the solution and part of the problem. In terms of Eric's point about that community engagement, when we visited the Dublin map, which we did before pandemic in November 2019, that would have been, they spoke about actually working quite hard, but that had to be an ongoing thing with their local community, but that they'd got to a point where that they had really good relationships with their neighbouring businesses and local communities. And if there were issues that arose, that they would work together. And they also mentioned the Garda, the the police being, the neighbourhood police being an important part of dealing with any concerns should they arise. So it's like a partnership approach. Hannah, I didn't know if you wanted to add any of that while I was speaking. No.
Thank you. I'm just going to take 2 more questions from the chat and then we'll go to a more general discussion. So Marcela Monteiro asks, is there a minimum age to be admitted to MAPS? And Harold Kleiman asks, how were the samples recruited? For the qualitative studies, I presume that is.
I'll take that. Generally there's not an age limit, a kind of age upper and lower limit. It would just be, it's more around alcohol use and homelessness. But generally, I think, as our data reflected, but also the data from Canada, is that most people are kind of 30, 40 plus. And indeed, actually, in the map in Dublin, I think most of the people who were there were probably 50, 60 plus. Some were even older than that. So it's generally, we know that younger people are maybe not, don't develop alcohol problems till they get older. So it's generally people are older, but that doesn't mean that they can't. There might be some maps that are particular for particular age groups, but on the whole, there's no age limit.
It might be different in terms of residential. Sorry to interrupt you, Hannah, because Bernie Pawley and team did publish a paper in Drugs Education Prevention and Policy last year on the peer-led drop-in map. And it may well be that drop-in services reach a different demographic. That's in Vancouver, that one. And I need to go back to the paper to have a look at that. But it might be that it's the provision. Most maps are residential. So providing residential supports as well, it might be that it's for the older demographic. Again, they're mostly men who receive the residential maps, not only though. So again, I think it might be different. If we had many more drop-in type maps, we might be looking at a different demographic, and also drop-in maps might be better at managing providing services for women and people that are not in accommodation, don't require accommodation services. So I think it's still a fairly early evidence base around that. Sorry, Hannah, you were going to take the point around interviews as well.
So for both studies, we recruited through a range of different ways, kind of drawing on our networks of people, so knowing people who are working in alcohol treatment, in homelessness services, and generally just kind of emailing people and asking if they'd be willing to participate. With staff, for the first study, it was we were able to do interviews face-to-face, so it was going along to the services and asking people to participate. And then recruiting clients was through staff members who would give them some information about the study, and then our researcher Tanya would go along and meet them in person. Obviously that couldn't happen for the second study during COVID, but Josh, one of the researchers, actually was able to do some interviews face-to-face because he was working in one of the Salvation Army services, and generally recruitment was through staff and our network.
I'll just jump in and say we did also try and specifically interview people from a range of perspectives that wouldn't necessarily be supportive of maps, because it's really, really important that the work informs the challenges. So we actually cast the net extremely widely and we got 40 different interviews. So they were pretty diverse, the views that we were able to get.
Great, thank you. If people would like to raise their hands if they want to ask a question, it may be different on your screen, but on mine there is a little button at the bottom called reactions, and then you can click on raise hand there. And I shall scroll through the screens, see if anyone has their hand up. Well, while we're waiting for that, perhaps one or both of you could say something about why you think Canada is so far ahead of the game here, and a little bit about the policy landscape in Scotland now. Are we ready for maps in Scotland, given that your research seems to be, saying this is what we need?
I think for Canada, why Canada? You have to have the first few, don't you? And then you get over that, that you broke it through. And hopefully the one that Simon Community and Lorraine might speak to might do that for us. because of so many difficulties that the front runners face in getting over that bar. And but I think that people died on the streets, they froze to death, and that did enable the community in Toronto and wider, I think in Ottawa as well, to really look at, well, what are the dangers and risks? And we've spoken about them all, but we haven't talked about freezing to death. But that is a risk of people not being able to stay in shelters, as they say, life houses, the hostels in Canada because of the temperatures that part of Canada experiences, which is different from Vancouver in the west. That people were not allowed in hostels, and they were dying on the streets. So I think that's partly why. And then once you have a bit of a mobilization to action, and then there was the Canadian program that's now 30. There's a number now that existed, and then COVID allowed that expansion again in these waves. And I think the research that's been done to kind of support the programs, to learn from each other. For example, there's a listserv and a community practice that Hannah attends, and that I know other people in Scotland attend now. And I think it's the visibility and having the pride in the services. They've made some films, they've had news programs on it in Canada, and I think there's a lot to be said for taking the issue on and explaining the alcohol to alcoholics issue, and really, and I think Indigenous health is really important there as well. The relevance of colonisation and the fact that many people that have got these extensive problems with substance use have many other experiences related to colonisation, residential schools, and many other layers of trauma that need to be recognised. So I think it's complex, but I think that's partly why. In terms of the policy context here in Scotland now, I think it's ripe for this, and I do hope that we're looking at delivering more maps in Scotland in the next very short future.
Lorraine McGrath, I wondered if you just wanted to come in there about what's happening in Glasgow, please.
Yeah, so we've been in discussion about developing a map for probably, I'm going to look at Peter now, it must be about 4 or 5 years since we had the first discussion about it, on the back of picking up on the work in Canada and the people that we supported. And I know, Helen will recognise that group of people as well, similar in Edinburgh, and just not finding solutions. And then when you look to the evidence and thought this is a really great way of doing something different. So it's taken all of that time really, and a lot of careful consideration and the support of an expert advisory group to get to the point where we have been able to establish a model for a full residential map, pretty true to the principles of the map. It's a 9-person site, so it's quite small, and that will allow us to have extremely personalised approaches. I'm in partnership with the ADP, who are providing the specialist and dedicated clinical interventions that wrap around it. So we won't have a clinical team on site, but we do have dedicated resource from the local alcohol and drugs partnership services. We are out to recruitment just now. We've been working closely with partners in Ottawa and elsewhere in Canada to look at the practice development and look at all the policies and procedures, etc., and to work our way through it, to work through the tricky regulation and governance arrangements that are required. So, as Tessa said, the first one is always the trickiest, and we're kind of breaking that ground, hopefully in the interest of other people that come behind us. But for us, as I said in the chat, this isn't just about this residential map. This is much more about working collaboratively to develop that model of practice, not so that we have a whole load of residential maps across the country, but that we have that model of practice so that we can develop a similar range to what they have in Canada. And for me, there's one of our big ambitions is that even people in Housing First in mainstream tenancies will have access to a map as part of that wraparound package. That's the big prize, I think, and it just becomes normal and ordinary. I mean, it's already mentioned in the addiction strategy for Scotland, so there's already that will behind it. So happy to chat to anybody that's interested in hearing more about what we're doing and how we're going about it. I can connect people with our programme manager really easily, and he's been immersed in this now for 9 months nearly. So, but we're close to it. We did have to make some changes to the building post-COVID and to improve the opportunities for people to have self-contained living. But we are very close, and I'm hopeful that in July, August, we're not making a huge splash about it, because I want to have the people themselves tell their story once they're in and they're settled.
Great. Thank you so much, Lorraine, for that update. That's very heartening news. I'm aware that we're running out of time rapidly. I wonder, Peter Rice and Harold Klingman, could you ask your questions quickly, and then we can see if Hannah and Tessa can answer them quickly. So Peter first and then Harold.
Yeah, basically, just to build on the point that Jonathan was making, you one of the authors of the paper, we found there's a big variability between maps in Canada. There were some better outcomes than others. I know that Tessa and Lorraine have both been out in Canada. So first of all, was that a surprise to you? And if so, what are the success factors for being effective, illustrative and effective maps? And there are ineffective maps, and how do we ensure that we get the elements right to make it an effective map?
Well, remember, I'll take that. Remember that effective is sometimes just what you're able to record, and that's in terms of the study designs. Your point, I think, has been already dealt with by the Canadian literature that looks at how the service guidance. I think the maps with the strongest service guidance around not drinking outside of the map, and that doesn't mean lots of really challenging rules, but it means bringing the service users within the decision making around maps and bringing them on board in terms of as co-producers of the maps itself. So I would say that having peers involved is really important, and having guidance in place, rules basically that everybody signs up to in advance is really, really important, and that's captured in the Canadian literature. I think those are the main things, and also how they get embedded in the community. I think that's also really important, but I don't know. And some of Bernie's papers can speak to that. I know I haven't got much time. It's important that Harold comes in with this question as well.
Thanks, Harold. Thank you, Tess. Harold, your question, please.
Yeah, well, I just have a short comment. It might be interesting to note that the first places where street alcoholics could meeting places, and where alcohol consumption would be tolerated, were set up in the 70s. For instance, in the city of Zurich. And it turned out quickly that most individuals who came to these places were not necessarily homeless, but went there anyway, and they could participate also in collaborative work. If they felt like it, they could talk to a social worker. In some cases, they might be put in contact with controlled drinking programs and so on. So what I'm trying to say that when you talk about maps, you have to talk about, you really see a continuum of interventions, and what we see in Canada and what has been presented in this interesting talk is, this is one possibility, more institutionalized, but if you call them wet places with some guidance and support, or you call them maps, it probably doesn't matter at the end of the day, but one should be aware that they are different shades. Also, how the modalities, can they bring alcohol? What are the rules? No other drugs, no aggression, no violence. Is alcohol provided? Is there some, is the consumption kind of recorded or not?
Thank you so much, Howard. I'm really sorry I have to stop you there, and we like to be on time, but I think that's a really important point about the continuum and what's existed prior to the idea of maps. I'd like to thank Hannah and Tessa so much for their really interesting presentations today, and the audience for all the comments in the chat. You can see that a few people have put their emails in the chat, including Lorraine McGrath. So if you're interested in getting in contact, please do so. And please join us for the final alcohol occasional in this programme, which is 2 weeks today, Tuesday the 15th June, where Wendy Masterson, also from the University of Stirling, will be talking about green space programmes for problem substance use. But for now, thank you so much and enjoy the rest of your day. Thank you.
Thanks everyone for coming. Bye everyone. Bye.